it's my great pleasure to introduce Judy Wyatt, who will talk to you now about the new pathways for liver biopsies. Judy, thank you very much.
Thank you very much, Peter, and thank you very much to the college for organising this webinar to introduce the liver tissue pathways. We wanted to start off with a quick idea of who is there in the audience. I can see at the moment there's about 160 people listening, and the first few slides are to have a quick poll to see who's out there listening to us. It's strange doing these Zoom meetings where you haven't got any idea if there's anybody out there at all. So we can see how many trainees, how many consultants, and whether you're from the UK or overseas. So I don't know if that's all right. I've just put that so that we can see a lot of consultants from overseas, a lot of consultants in district hospitals, and a fewer number of trainees. So 34% of overseas consultants. The next one is, have you ever looked at the liver tissue pathways before? The first edition was done in 2008 and the second one in 2014. And so whether you're a consultant or a trainee, can you just indicate whether this is a document that you're familiar with and have had occasion to use in the past? Consultants using it once. Oh, I haven't even got consultants using it more than once a year on my screen, but consultants using it at least once seems to me the majority. So at least you're familiar with them. The next one, roughly how many medical biopsies do you see and report each year? Liver pathology is done in a very wide range of settings. Some people see next to nothing in the way of medical liver biopsies, especially these days, and some work in centres where they see plenty of experience, and it's something that they do every day. And it's come in, so typically the audience is people seeing less than one liver biopsy a month, and trainees seeing very few biopsies feel not enough for their experience. Very few consultants in this audience are seeing more than 1 or 2 liver biopsies a week, most seeing 1 a week or less. That's great because that's just the audience that we have in mind for the tissue pathways. And I'm trying to get to the next slide now. Here's the picture of 4 liver biopsies, and can you just choose which of those you think is the most similar to your typical liver biopsy for medical disease of where you're working? There we are. And so the typical one is this one, which is number C is just about half of the delegates, and a few lucky people have biopsies like this, 16%. Okay, so without further ado then, moving on to the next slide. What's new in the liver tissue pathways? Well, that's just a quick overview slide, and all of the highlighted bits are new since the second version of tissue pathways. So there's a lot of new things. The co-authors, Stefan and Chris, have been with this from the start, and this time we're joined by Sue Davies from Cambridge, and I'll show you why in a moment. The tissue pathways are very much the test component of using medical liver biopsies, what to do with the biopsy, what to put in the report, and some comments about governance, quality, and audit. And the first 2 versions of this were really standalone documents, which I doubt if anybody outside pathology was aware existed. If you talk to clinicians, they think of biopsy not as a noun, that this is a tissue sample, but as a verb. This is taking a biopsy, and the tissue pathways were written in parallel with the new updated BSG guidelines on the use of liver biopsy in clinical practice, particularly the pre-test component. And it was really useful from our point of view to be able to refer to the equivalent documents in writing both documents. You'll see that 3 of the authors on the tissue pathways are the same as those in the guidelines. You'll be aware that the indications of liver biopsy, for medical liver biopsy, have changed enormously in the last 10 years because we're no longer seeing biopsies for hepatitis C. There are now very clearly defined algorithms for investigation of liver disease. So biopsy is specifically indicated when the clinicians can't get the complete answer with non-invasive means. So the indication for biopsy is generally clear and well known, and the biopsy interpretation is probably more challenging therefore because it's in complicated cases where there's ambiguity about non-invasive tests. So biopsy specimen quality is even more important, and this is a major change in the current tissue pathways. Just looking in Leeds 2011 to 2019, the changes in our spectrum of liver disease, viral hepatitis was already on the way out in 2011 and has largely gone with just a few hepatitis B left. Its place being replaced by fatty liver diseases, one sort or another, and this is likely to remain high as treatments develop for fatty liver disease and probably ultimately go down, leaving the really important group where the biopsy is necessary for a diagnosis. Just to mention in passing that this tissue pathways does include a section on targeted biopsies for tumours, but I don't want to say anything more about that today. There are appendices which have immunohistochemistry and so on that you can refer to, and this duplicates the section on targeted tumour biopsies that will be there in the dataset document, which is currently working its way through the college process. The quality of the liver biopsy sample is really crucial. If you haven't got a good biopsy sample to start with, then any comments you make about it might not be very valid. There's good evidence base that you should have a 2 centimeter long core with a 16 gauge needle that gives you a 1 millimeter diameter section to obtain sufficient portal chats reliably to be able to avoid underdiagnosing or under-recognizing the severity of disease and missing focal lesions. There still remains some variation, sampling error, but it's minimized by having a good sample quality, and that's what you should be aiming for. Over my years as a consultant, starting in 1987, we used to get enormous biopsies. They went very small. When the radiologists started taking them instead of clinicians, they've gradually been getting bigger. And now we consistently get these 2 centimeter long 16 gauge needle biopsies, which makes our interpretation much more reliable. There's a host of different gadgets that the radiologists can use to take percutaneous image-guided biopsies. The biopince needle is the one that we're using here, which gives you this nice long core of up to nearly 3 centimeters. In fact, our previous one had a maximum length of under 2 centimeters, so would never really be ideal. And we've got some clear audit criteria now for good, compromised and inadequate liver biopsies there. The clinical guidelines really emphasize the importance of the knowing the purpose of the biopsy. So we should get all our requests with a clear indication for the biopsy now. And we should be able to write a report that answers the question which is posed by the clinician taking the biopsy. Just to mention in passing 2 scenarios which have often in the past led to misleading results. Firstly, if the biopsy is done without any known clinical diagnosis, the clinicians are looking to us to guide their next investigations. So we should try to go a bit further than just saying chronic hepatitis and say what we think the pattern of disease is indicating to investigate next. And then secondly, the clinician suggests one or more specific diagnoses. This is the commonest scenario now as a result of extensive non-invasive liver investigations. Clinicians end up with a dilemma because they often have more than one disease or unclear about the stage. And they're asking us to resolve their dilemma for us. So we should avoid simply agreeing with consistent with a suggested diagnosis, but we should try to solve the question implicit in the biopsy for them. What to report in the report? Well, this hasn't changed, and this is, of course, good practice for any sort of pathology. It's really useful to start off with the clinical information that was received with the biopsy, because often that isn't very complete, and it gives sets the scene for the biopsy interpretation initially, although hopefully that can be elaborated with clinico-pathological dialogue later on. An initial overview of the architecture is really helpful because you can then slot the biopsy into a spectrum that runs from no evidence of chronic liver disease, no fibrosis, up to the late stage of cirrhosis. Regardless of the underlying cause of disease, these stages are very useful for the clinicians in assigning a patient to a particular clinical pathway. Description of the abnormalities, not just that there's inflammation, that there's fibrosis, but try to look beyond that and to simulate the pattern of disease into one or more disease patterns. And there's a summary of them here. I'll show them a little bit more in a minute. This takes a little bit of practice, but it's very satisfying to do, and it guides the clinical scenario that you're likely to be dealing with. Then you can put this diagnosis into the clinical context rather than the other way around. And this is why we recommend looking at the biopsy first before the clinical information, so you get a feel for what might be going on before you're misled by clinical information, which might take you in the wrong diagnostic direction. Comparison with previous is useful, and I think we'll say more about scoring in the Q&A section at the end. Liver biopsy reports can get very wordy, and it can be difficult to know what you mean for the results. So a concise single line summary is helpful. And of course, any consultations and second opinions if you've sought them. Just to mention the appendices again, there's 9 of them at the end of the tissue pathways, including one about the liver special stains. And to draw your attention to the main patterns of disease, the little summary here is elaborated into acute and chronic disease with the patterns, the clinical significance, and some comments about pitfalls and where you might want to elaborate or consult special stains a bit more. Who reports the biopsy? So this is very dependent on the scenario that you're working in, and this spectrum is reflected in the audience that we've got today. This is some results from a similar question to the pathologist in the Gloucester GI course 10 years ago now. Most of them would be GI or general pathologists reporting less than 20 liver biopsies a year. On the other hand, the members of the liver EQA scheme, which I'll say a bit more about at the end, at least in 2013, had an enormous span of less than 5 up to more than 500 biopsies, including the people working in the liver centres, but also a good proportion of interested pathologists not seeing a lot of liver biopsies, but maintaining their CPD and their interest in liver pathology that way. So the situation that you work in will drive the pattern of service that you're able to deliver. The emphasis with these pathways is the opportunity for easy referral to a centre, both for the patients by the local gastroenterologists, and this is very much formalised now in the way that hepatology clinical services are developing, and also for the pathologists, either because the patient's being seen centrally or because your biopsy is tricky and you want the input of somebody who sees more than you do. Second opinion, there have been several studies looking at where discrepancies arise between the primary diagnosis of liver biopsies and the review diagnosis when they're referred to a liver centre. And of course, this is an enriched set of patients who have the more complicated and challenging disease and biopsies. And so this shouldn't be taken to be a proportion of biopsies which are misdiagnosed overall. The biggest of these series comes from Cambridge, and Sue is here in the Q&A session, so we'll be able to give you more details about this later on. So I've extracted data from that because I think this is really insightful. If we work in liver centres, then we depend on seeing and gaining experience from a range of referral cases. So these are a good thing for us to have. In this series, there were 12% major changes in diagnosis on review and quite a lot of minor changes which nevertheless affected patient management, so that over 40% of reviewed biopsies centrally had a new diagnosis, a change in diagnosis that affected the management of the patients. And although those span the whole range of different indications and diagnoses on liver biopsy, there are 2 in particular which are highlighted as difficult from this study. One of them, 130 major changes in diagnosis, the biggest by far is biliary disease not being originally recognised. That accounts for about 1/3 of them. And another 10% or so are vascular diseases, which are subtle and not very common and not familiar to a lot of us, often helped by doing an EVG stain. If you look at this as a proportion of the overall biliary diseases that were diagnosed centrally, 1/4 of them hadn't been recognised in the original pathology report. And 50%, half of the vascular diseases, hadn't been originally recognised in the original original primary histology report. And that is the evidence base for the conclusion that it's strongly advised that because of its difficulties in diagnosis, specialist review is considered in these situations. Autoimmune disease, on the other hand, often overdiagnosed, may not be that on review. Biliary disease and vascular disease often underrecognized. And just to finish off quickly, the audit templates, which the college also produces, if you want to develop your clinical service, you want to study your own biopsies and work with the clinicians, then I think people have found these 2 audit templates to be very helpful to open up a dialogue with the clinicians and address the biopsy quality and the clinico-pathological dialogue. And finally, to introduce you to the EQA scheme for liver histology, at the moment there's 116 members, but we've introduced some big changes in 2021, which have the effect that we can open up the scheme now to more people who want to use this as a way of checking their diagnoses and having very first-rate CPD educational opportunities. Instead of using boxes of slides, we now use only digital slides. We use drop-down menus, so that makes the collation much less subjective and easier to do. And we found the Zoom meetings, which we were enforced to do last year, really helpful. So the consequences is the potential for lots more people to take part. Members of the EQA scheme also become enrolled in the UK liver pathology group. And we have an aspiration to support excellence in histology for livers across the whole spectrum of clinical service provisions with education and CPD. So in summary then, what we've said already, the new things emphasised are the link to clinical guidance, so that the clinicians will know about our pathways now. There are changes in indication for biopsy, as a result of which the biopsy sample quality is even more important than it was before. The importance of communication is really emphasised, and the clinicians will recognise that as well now, and should seek to have a dialogue with you over their medical liver biopsies, and to support second opinion pathways, networks being opened up and available for everybody. And a link to the liver EQA scheme, and recommend as a way of maintaining consistency in criteria and diagnostic terminology around the country, and in supporting you if you want to do liver biopsy reporting in whatever scenario. And just thinking ahead, another 6 years, 2026, I wonder what life will be like then. And that's the end of my presentation.
Judy, thank you very much indeed. That was a very full and amazing how you managed to cover so much of that very effectively. Thank you very much. There are a number of questions have come in, and thank you to those of you who've submitted them. And I'll start with the live questions, the number of topics, but the first one that's in is about chronic hepatitis and how that disease process is scored. The question is, what is your take on scoring chronic hepatitis, especially in cases reported in district general hospitals? And I think Stefan was set up to address these chronic hepatitis type questions. Stefan.
Okay, thank you, Peter, and thanks, Judy, for an excellent presentation. If I perhaps just ally that to 3 questions we had submitted prior to the meeting, which were, what is the recommended grading and scoring for chronic hepatitis as per current guidelines? Another question related to the latest scoring system for chronic hepatitis. And there's also a question about which grading and staging system is used most commonly for non-neoplastic liver diseases. And they're all part of a common theme. They're very good questions, not easy to answer. I'll try and be as succinct as I can. I think the first point to make is that these all have applications and limitations. And most of the scoring systems, I think, were mainly devised actually for assessing disease severity in the context of clinical trials. And I believe they have limited use in routine practice, and one has to bear that in mind. A distinction needs to be made in response to one of the questions between disease activity or grade, which is potentially treatable, for example, inflammation, and that may be very relevant in the setting of, for example, autoimmune hepatitis. And disease stage, usually fibrosis, which indicates progression that's less likely to be reversible. The other point I think to make as a general comment, before I try to answer some of the specific ones, and this was alluded to by Judy, is that 2 things have greatly reduced the use of liver biopsy for assessing disease severity. One is the use of non-invasive methods as surrogates for liver fibrosis, notably FibroScan, which measures the stiffness of the liver. And secondly, advances in treatment, particularly in the context of hepatitis C. And Sue and Judy will remember, we used to get loads of biopsies for staging hepatitis C, but I haven't seen a hepatitis C biopsy for the last couple of years now as a result of that. So things are changing. So in terms of current scoring systems, I don't believe there have been any that have come new kids on the block, as it were, for chronic hepatitis in the last 20 years. They all have advantages and disadvantages. I think you need to remember, you need to use a scoring system that's appropriate for the disease in question. So there are different systems for chronic viral hepatitis, biliary disease, and fatty liver disease. And I don't think it matters which system you use, so long as it's one you're familiar with, and both the reporting pathologist and, importantly, the clinician who reads the report understands what the scores mean. And I guess as a final point, I'd say, please don't use scoring system as a replacement for conventional reporting. It is an adjunct. And I think a particularly important example of that is diseases with a dual pathology. For example, you don't see this much anymore, but hepatitis C and non-alcoholic fatty liver disease frequently coexisted. And in that setting, it's much more important to try and work out which is the dominant disease, rather than trying to apply a scoring system which actually won't work for either, because they've got components of both. And I tried to be succinct, but I probably wasn't, but I hope I've answered all the various questions about grading, staging, and scoring it in one go with that reply.
Thank you, Stefan. I think it was succinct. Thank you. We've got a question in from someone who's asking, can overseas consultants become members of the liver EQA scheme? I guess, Judy, can you answer that one?
Yeah, so at present, no, you can't take part in terms of sending in responses and having them collated, just because the amount of work involved has been enormous. If we're successful with our drop-down lists, then we, like some of the other UK QA schemes, would be in a position to include members from overseas. They often would be fed back a score, but not included in the ranking that we use to identify the low performers within the UK context. And the same will go for trainees. So we don't accept either at the moment, but within the next year or two, I think that would be possible. And in the meantime, you should know that on the liver pathology website, if you do virtual pathology into Google and then find the UK liver pathology group, there's a huge number, there's over 400 now of previous cases from the EQA, all with the views of the participants and the agreed diagnoses, which is a tremendous resource for training yourself and knowing whether you're in line with other people's diagnoses of those cases.
Thank you. And I think that the point you make there, Judy, is well made too, about the fact that the purpose of EQA, at least interpretive EQA, such as you're talking about, is primarily educational and developmental. So that's what it's intended for. And thank you for talking about these resources. The next question is about portal track counting. We've talked a wee bit about counting, and I'm going to ask another question about that just shortly. But the question is really, where did we arrive at the portal track number of 10, having increased from 6, and calling this adequate or inadequate? What are the risks of calling more biopsies as inadequate based on the fact you don't have enough material to work on?
It's okay if I respond to that one as well, Sue and Stefan. The evidence base was a couple of papers in 2003, in particular one by a group called Colorado, where they reduced the size of biopsies and looked at the effect of the reduction of size on the grading and staging of a chronic viral hepatitis, and found that once you got below 10 portal tracts, you really started to underestimate the grade and the stage. So they came up with that paper is really where the figure of 10 comes from. There's a lot of subjectivity in counting portal tracts. It's not an exact science, but it does give a general indication of the adequacy or not of a liver biopsy. And the important thing from the radiologist's point of view is how big a biopsy sample do you need if you're going to reliably have sufficient tissue to enable the pathologist to be confident in their report. And so the length of the biopsy and the gauge of the needle are the important things for that. And devices have come along since the pragmatic solution in the previous one, tissue pathways, where radiologists were concerned about using a wider gauge needle and most devices didn't give you a very long core. Now devices can give you a longer core, and the radiologists are very much on board with being able to supply a sample which is diagnostically useful for us.
Thank you. Just keeping on it's really about counting again, but this time it's about whether digital counting, or are there tools which allow us to use IT to count structures, given the fact that we're actually not very good at counting things. We're quite good at observing them, but counting them we get quite a lot of discrepancies. Has anybody tried using digital when it comes to identifying and counting structures automatically?
It's not something I've got any experience with.
Anybody know that one?
Not diagnostic, no.
Okay, good question. Just send it back to the originator and say, Doctor, there is a research project waiting for you there, I think, and I'm sure you'd get collaboration around this room in doing so. Someone asking for a practical point, a list of referral centres for possible second opinions, and if it's possible, can we include that on the pathway? So tricky one that as regards advertising, I suppose. But the other piece in that is, do we consider digital slides for second and expert opinion as a possibility? And I'll add a third one to that mix when you've asked these ones. When we've addressed these ones, rather.
So, do you want to?
Should I just say there are really, the pathology is going hand in hand, obviously, with hepatologists, and there are local networks that have been set up because it's realised that in DGHs, the gastroenterologists with a bit of an interest in hepatology are looking after the liver patients, and there seems to be potential for massive improvement with the liver improvement quality scheme. And so there are local networks being set up, and nearly all of those will have a hepatology centre, including and beyond the 7 liver transplant centres that exist in the country at the moment. So there's the local pathway is there. If you have, and the patients will go on that pathway, so it makes sense to use your local centre for the pathology review, but there's absolutely no reason why you can't ask outside of that region for a second opinion of a pathologist who you have perhaps already a relationship with, and we all need a second opinion on occasion.
Yeah, thank you. And do you think that digital is a way forward for this?
I think digital, we've actually used it already. We're quite a big region, and we use it. People have been working at home as well through COVID, and we've been getting second opinions and live discussions, and I think it can be incredibly useful. Personally, I haven't done any primary liver reporting at the moment. Well, not for several years, and I was not happy with doing it. But I think, Judy, have you started doing primary reporting?
I'm undergoing my validation. I have to say, for somebody who spent something like 34 years looking at glass slides, it takes a little bit of transition. It's brilliant for teaching, for sharing, Teams meetings. It's very good for our clinical meetings. But that last step of losing the safety net of actually getting the impression of a glass slide isn't something I've jumped to yet. But I can see that that's going to be I think a tipping point that happens quite quickly for us. And I can see that the advantages in, for example, being able to work together with a local district hospital pathologist, with a Teams meeting and their clinician, because in my experience, the difficulty with outside biopsy, or providing a service for district hospitals, which we're beginning to do now with the big change in the spectrum of liver biopsies being taken. The difficulty is getting the good clinical tie-up, and I think it's really quite exciting that I'd be able to, me, a local pathologist and a local clinician would be able to get together in the way that Sue, I think you used to do with Peterborough, was it, that you used to travel to?
Norwich, Norfolk and Norwich. We do it all
yeah.
by video conferencing now, and we can also share cases outside of the meeting depending on the clinical need.
Mm-hmm. Yeah, I think that's excellent practice, really. I think the question that I was going to come to was really, would it be perhaps more effective and efficient to find some way of building the expertise of local pathologists rather than relying on secondary referral centres? And perhaps, as you suggest, using digital in that format may actually be helpful in that regard and allow us to broaden the influence and thereby jack up the standard across the piece. Because I think one of the things that is apparent is the need for communication around these patients, because they're often quite complex to deal with, and how best do we maintain that?
I think that's a really important point. And I think what Sue was saying about the histology services paralleling the clinical services is precisely that. There's a huge number of patients potentially with liver disease that can't, of course, all be managed in the centres, and so this centrifugal or centripetal flow of patients to keep them near their home and near their local services is important. And I think lots of pathologists actually really enjoy the challenge of doing liver biopsy. It's real medicine, and you have to think in differential diagnosis terms and tie in lots of different aspects of a patient's situation to get to the best diagnosis that you can. And that may also evolve over time. So I absolutely, I would look forward to a situation where patients can be well looked after with good histology input, but that can be provided locally to them.
Yeah, thank you. We wanted to turn to the EQA question, and just a couple of people actually have asked about EQA following on your comments earlier. Judy, just saying it's very appealing, the invitation to join the liver EQA to provide the consistency and support for learning. But how about those who just want to join for education only rather than be marked and potentially get told they're underperforming? Not that people are underperforming, of course, but it's just that perception that that there is a level, but if you're keen to develop that level of capability, you have to start somewhere. And how do we build people's confidence without destroying it, or build people's capability without destroying their confidence would be the question. And so it's around how do we encourage people into the EQA system in a way that promotes that educational benefit without undermining their professional perceptions of their own abilities.
Well, I think I've always found that to be able to compare my diagnosis with lots of other people is a very powerful learning tool. And I still learn things. I still make mistakes once in a while from the EQA. I think, firstly, that people aren't, during the first two circulations, they're not included in any ranking calculations anyway, so people have a chance to get used to how we do things. Now that we're assuming our pilot for the drop-down menus works well, then that means that we can scale up the number of responses that we're dealing with easily and quickly. It's very laborious reading a lot of free text boxes. People write essays about their liver biopsies, and it's very subjective. And I think I'm just seeing the results now of this pilot for the drop-down menus, and I never thought it would be possible for liver biopsies because I thought there was such a range of subtleties in them, but actually it clears, it's based on those patterns of liver disease that are in the pathways, and it shows up the outliers remarkably clearly. And you being within the 1% of people who thought of something and nobody else did is a really powerful learning thing in a safe environment, because no patient's getting damaged by that. and you can know that your diagnoses are as good as the rest of the people in the UK practicing. And you're right, Peter, it's really unusual for people to be a persistent low performer because they take action on it. They worry about it and they work hard, and that in itself is if you're low once, then you try very hard the next time, and repetitive poor performers is vanishingly rare.
Yeah, it's an important message, is that most of us do pretty well most of the time. And I want to go back to scoring and grading again. There's a couple of questions in here. One is about, would you recommend or not estimating the degree of fibrosis in suboptimal samples, where you should probably estimate the amount of scoring? Yes, Stefan.
So thank you for that question. Yeah. So it's a tricky one. I think as histopathologists, I mean, we're clinicians, and we should have the ability to be honest and comment on biopsies which are suboptimal, which is rare in my experience these days, or even inadequate. And if we feel there's inadequate tissue to answer the clinical question, then we should say so. And the person who has obtained the biopsy, usually a radiologist, may learn a bit from that and try and get a bigger sample the next time. That said, I don't think we should be bound rigidly by saying if a biopsy is less than 10 millimeters or 15 millimeters, 20 millimeters long, or it has less than a certain number of portal tracts, which we actually can't count very accurately. And Sue may wish to come back to this. I know she has views on that. You don't need to be bound by that. And it may be possible, even in a small biopsy, to see obvious cirrhosis. If you've got mostly fibrous tissue with a couple of nodules in, you can say it's cirrhotic. So we should always attempt to get the best value we possibly can out of a biopsy, no matter how small it is, but also be honest enough to say that our diagnostic facility has been compromised if there isn't tissue.
I completely agree with that. I think, quite often we say to people, I'm sorry, but this patient deserves a proper diagnosis, and we can't really do that. And in the weight that people put on the results from these biopsies, we really have to have something decent to work with. And I don't think as a specialty we should be afraid of saying that. It's not protecting our backs. It's about making sure patients have a safe diagnosis. And I think that's a good measure of it. If you think it's safe, then do it. If you don't, then don't, I think would be my answer. We've just got time for a quick last question, which I think probably comes to you as well, Stefan. It's about, can CK7 be used for portal tract counting?
Oh dear, that's a difficult one as well. It depends what you're using CK7 for, of course, because if you're using CK7 as a marker of bile ducts, then in a vanishing bile duct disease, the portal tract may not have a bile duct. It will have ductules. Keratin 7 can also be expressed in central lobular regions in conditions of hypoxia, fatty liver disease, and even one can literal ducts in central lobular regions. So you can be mistaken in thinking that a central lobular area is actually a portal tract. So I would say that I think Keratin 7 is a brilliant stain for lots of things, but I'm not sure it has a particular role in counting portal tracts. I've just seen a question actually that's far more important than any of this, and that is somebody commiserating with me about, I only have two interests in life. One is liver pathology, and the other one is, or are the misfortunes of West Bromwich Albion Football Club. And somebody has commiserated about West Brom being relegated this season. And thank you for sharing my grief.
And thank you very much. The plan is to have these webinars as a resource available so people can go back and look at them as a learning tool going forward. We also hope that we'll be able to use feedback from the guidelines and from pathways and the presentations towards building the next generation of pathways and guidelines. And so what you think about the implementation of this is all very helpful to the people who are constructing these guidelines. It's also important, I think, that everybody knows that the college, along with everybody involved, is very keen to involve new people in producing guidelines, because we want to be as inclusive as possible across pathology to encourage new people into developing interests and providing us with help to establish the college in the role of providing such guidance. And the broader the church we have for that, the better. So that is an invitation to everybody to do that. So going forward, when we see things being advertised, I would encourage everybody to take up those offers and put yourselves forward for this sort of activity. And finally, I would just like to thank everybody, particularly Judy, Stefan, and Sue, but also Chris, who isn't able to be with us today, for all the work that's done in drawing up these pathways, providing us with the guidance that comes from them. It's a lot of work and difficult to do and to keep up to date. And to thank the team in the college for ensuring that we're able to deliver this today, and thank all of you very much for your participation. Thank you all very much, and good afternoon.